Hello, the title of this presentation is How does health information technology impact on patients and staff within urgent hospital care pathways? I'm Katharine Abba from the University of Liverpool. So at the moment there's an increasing number of hospital admissions of people with chronic conditions, and at the same time there's a move away from the old handwritten case notes towards more digitised records and the greater use of health information technology. So the big question is, how can these digitised records and health information technology be used to improve services for people who have unplanned hospital admissions? So we decided to do a qualitative study with NHS staff to ask them what they thought. What works best now? What doesn't work so well? And how might things be improved? We focus on 3 ambulatory care sensitive conditions: COPD, epilepsy and alcohol-related illnesses, and we included 4 acute trusts, 2 that still use mainly handwritten case notes and had various health information technologies running alongside that, and 2 that use a digital health record with their health information technologies integrated within that. And to make sure that the whole patient journey was represented, we also included an ambulance service, specialist nursing services, regional neuroscience centres and a GP practice. In the analysis, we identified 2 main themes. The first theme was the fragmentation of records within the organisations, and this was particular to the hospitals that still use the handwritten case notes. And this was inefficient and was frustrating to the staff as they had to click in and out of various different systems on their screen and sometimes had to read scanned copies of handwritten case notes that were not always very legible. And the second theme was the fragmentation of records between organisations, and this was common across all 4 trusts and all of the other organisations as well. And this was seen to have a more serious effect on patient outcomes and patient experience. So common problems identified because of this fragmentation include patient safety being compromised in a crisis, as alerts that had been recorded were not accessible at that point. So for instance, patients with COPD who retained carbon dioxide when given high flow oxygen, this might be recorded, but if the ambulance service couldn't see that record, they might still give that patient high flow oxygen. And then there were unnecessary admissions or inappropriate treatment due to not having access to relevant history. For example, not being able to see previous blood test results and therefore not seeing a trend and not being able to tell whether a condition was acute and requiring admission or stable and not requiring admission. There were missed opportunities to intervene as patterns in a person's attendance were not identified. For example, patients who were attending emergency departments more regularly, whose condition might be worsening. There were also problems around sharing recorded end-of-life plans or ceiling of care plans, meaning occasionally end-of-life preferences were not met or patients were having repeated discussions which could be upsetting. And there were safeguarding risks, as safeguarding information was not shared between NHS and non-NHS organisations. So we concluded that health information technology could play a really important role in helping to improve outcomes for patients who were having unplanned hospital admissions because of ambulatory care sensitive conditions. And we also concluded that it would take more than just health information technology, as trusts that had that technology were still not able to share information effectively. It required systems and cooperation. So information sharing needs, they did vary by condition and geography and local situations, but there were some core priorities that we identified, and I'll leave you to just read those on your own. Okay, thank you very much for listening.